So, Karina, thank you so much for joining me today and helping me with this recording. It really means a lot to talk to a fellow midwife. And do you want to just introduce yourself so everyone knows a little bit about you?
Sure. My name is Karina Edwards, and I'm a community midwife, and I have been serving moms and babies, well, families for over 20 years, specializing in specifically women's health. And I am a part of the Common Sense Childbirth Institute team, National Perinatal Task Force, and working towards improving outcomes in my state and nationally.
And of course, you're in Georgia, which at this time at least is still, I believe, dead last as far as maternal mortality in the USA. And
yes,
so important to really recognize where you might be working as a clinician and understanding how things are in the state that you work in, but also in the county, in the city, in the village, in the region, wherever you are. Put yourself in context as you do this work to make sure you really understand the environments and the ripple effect of the environments out from where you stand or where you operate, and how those also impact our families. So we're talking about perinatal mood disorders today, particularly really honing in on how, as a clinician, particularly a JJ Way clinician, you can have an impact on that. So,
yes.
Karina, I know you are very familiar with this situation that, and it's not been named as often as I think it should be, but that women who are suffering from depression, anxiety, overwhelm, it's not just postpartum. It's often in the prenatal period. Of course, it's often before the pregnancy. And I think that when we use the term perinatal around mood disorders, we really need to clarify what that is.
Yes. Yes, absolutely. Many people suffer during the time, and some of it is circumstantial that can trigger, what is happening, but it's often, it can be hormones, it can be just the overall change. And a lot of times, even if your environment and your home life is okay, you're dealing with a system that is just really damaged and needs fixing. So that alone can contribute significantly to perinatal mood disorder. And during the pregnancy, afterwards, interconception, it impacts you when you don't have access, or when you have access but it's not quality, or you're not treated well.
Exactly. I think that this is one of the burdens for clinicians, particularly those clinicians who aren't working independently or in environments where everybody and the whole system and structure is set up to be supportive in the way that we operate JJ Way. So if you are a provider in an environment, perhaps a hospital or a large hospital system or clinic, health department, community center, where you may have to be sort of this lone wolf for a minute as you begin to integrate this way of practicing. I want you to really keep a strong focus and keep an intentional mind around how we address perinatal mood disorders, because just like Karina says, they go throughout the entire prenatal course. Yes, so it's important then for us to think about how can we impact perinatal moods, which may be going on throughout the course of the time we're in interaction with the mother, baby, family, but also after we're in interaction with her. Some of our clinicians are not going to even have much access to her. They may only see her during the perinatology exam, or they may only see her during the labor and delivery, or they may only see her one time for the postpartum, 6-week postpartum exam, right? So anytime that we interact with mothers, babies, families, we want to keep in mind that there's more likely than not, that there's some type of underlying mood concern, whether it is just slight depression, baby blues, anxiety, even psychiatric level.
Yes.
and that we will not necessarily have that information from the patient. It's a difficult thing to disclose, and many women will hold those kinds of feelings and those thoughts because they don't feel it's safe to express that what's going on for them.
Mhm.
So, Karina, talk to me about how in your work as a clinician, as a midwife, you've been able to maybe tease out, a question or an open-ended inquiry that has helped a mother to disclose how she's truly feeling.
Sure. I had to shift maybe about 5 years ago completely how I was even working, because I ran into a mother in the grocery store who I hadn't seen maybe a year since she had given birth. And I remember I had tried reaching out to her a few times and never heard back. And she said, well, my husband and I almost divorced. I had really bad postpartum depression and I had no idea. And I felt terrible. I felt like, wow, how did I miss that? Especially because I experienced similar, and I had people checking in on me. I was in Canada where we get a nurse's visit once a week to check in. And I still had severe depression. So for me to miss that, it really bothered me. And I changed how I practice. I just included questions throughout the entire process, checking in, looking for different signs, because people don't share, especially you get some, it doesn't matter who it is or what their background is, but this particular person came from a corporate background. So she went from, being in corporate America to now I'm just a stay-home mom. I'm just, and so you would think, okay, you don't have to worry financially. You don't have to worry, you can stay home. But no, she felt like I'm just a mom. It was still impacting her. So I had to learn how to, here I'm always seeking to go over and beyond for the parents who have less and who you assume are struggling more because of their circumstances, but it's really across the board. It's with everyone. It's with everyone.
It is so important, and thank you for making that point, because this is one of those times when we make our stereotypes, we fall right back into the tropes. We, as human beings, it's a human being way of being, but it is important because we think we know, or we should know, or we have some understanding where maybe there's none. This is a leveler. Perinatal moods is across the board. You would be shocked at the people who have suffered or are actually in the middle of suffering and do not disclose. I think one thing that women are really good at, we're adept at hiding what's going on for us. And so I do feel like as clinicians, this is our opportunity to just assume that everybody might be having a problem and open up conversations that will allow them to express that, disclose that, and allow them to really get the safety in the interaction that they have with the JJWA practitioner. So just to recap really quickly, those 4 tenets always show up whenever we're trying to practice this skill. First of all, access, connections, knowledge, and empowerment. If you provide an access point every time without fail, it becomes routine and it becomes normal, and it actually becomes expected by the mom that when she's meeting with you, she knows, because this is always the same way. It's reliably so, and she can build and hold trust in the space when you're in an interaction. So it's not that someone might not disclose because they don't trust you, but it's just that they will answer your questions if they trust you. So the question has to be posed, because in the absence of the question, the visit can be done, everything can be great, everybody's having a good old time, but we never get to the understanding. So access is provided by asking.
Yes.
The connection allows the answer, the trust is there and the answer comes forth. Knowledge can then be shared on whether it's a resource, whether it's a tip, whether it's here, you can call this emergency line 24 hours or whatever. The knowledge is shared. You learn about what she's dealing with. She learns about what you can do to help her with it. And both of you end up empowered.
Yes.
You were going to say something.
Yes. And when you're in a hospital setting, especially, or you have a practice that's a little bit bigger or just multiple people, because, as you know, for a lot of clinicians, keeping your head above the water and dealing with your own trauma from just being a clinician and dealing with the different politics and everything, you can drown in that sometimes and forget to check in and remember that this person is in my practice and I'm seeing them, but have I seen them enough to really build a rapport where they truly trust me? And so they're not going to just voluntarily bring that up. And I learned that from being a doula, where I met somebody in the parking lot after her postpartum visit with her person who actually helped her birth her baby, as the clinician. And she was a ball of tears in the parking lot. And she said, I don't know why I didn't say anything while I was in there. I was in there and I just said nothing. And now I'm out here with you and I'm saying everything. And I think that, we have to be really careful with that, and knowing that even if they trust you, they may not feel comfortable with bringing things up if they haven't spent a ton of time with you, per visit. So that's really important to remember too. We can't assume that, hey, this person likes me, they're going to open up and everybody trusts me because they allowed me to be a part of their process. That's not how it works, and we have to acknowledge that and be very careful to not assume anything.
I agree. I think this is why I consider this skill a skill building exercise, that we have to hone and strengthen the muscle that is discerning, the muscle that is compassionate, the muscle that is listening, because we can't always solve it, and it's not our role necessarily to solve it, but it's a part of letting the patient know that we are very prepared to hear her story and to support her. So that includes perhaps getting the resources together ahead of time and knowing those resources and knowing they're reliable, vetting those resources. I think there's nothing worse than referring a mother who's in trouble to a provider that actually isn't going to be able to follow through, isn't culturally safe, isn't available, in ways, and we already know that, and don't participate in that. So it takes that preparation and being ready for, but it also takes that willingness to open up to the patient and let her know, okay, I found that this person or this resource or this clinic or this resource is very capable of helping you in the way you need help. And I trust them to do that for you. Here's the number. I understand that sometimes this visit is a rushed visit and we don't have time and you've got to get the kids from the school bus. And so let's not talk about this now, but would you give me a call and we can talk, or may I call you and we can talk further at another time? If you're doing telehealth, how can is the room safe for even any of this to be discussed, right? Our side is having awareness around, underneath, behind, alongside of what the potential answer might be to our question, not judging the answer or not thinking the answer is in of itself the answer and that we're done, and recognizing that in the absence of us doing any of these things, nobody else is doing them either.
Right.
There's literally nothing going on. So in the prenatal course, we're doing prenatal care and we're really caught up with that. But in the postpartum, there isn't even any provider, let alone access to support when you have especially a serious level anxiety or depression or psychosis. We leave our postpartum mothers in America just wide open, hanging with nothing and nobody. And so those are big shoes to fill. Those are big gaps to take care of. Yet we can start small, we can start slow, and we can take personal responsibility for recognizing that we are in action now to fill those gaps, to bring our team members along with us in filling those gaps, to educate and support our staff and our colleagues, and to keep speaking about the fact that perinatal mood disorders, as far as pregnancy and birth is concerned, is a serious problem. And in fact, the biggest cause of morbidity and mortality in the United States when it comes to perinatal issues.
Yes.
So as far as being a clinician and working in this sphere, Do you have any other tips for clinicians that are beginning to work in this way, to practice this model, in terms of how they may prepare themselves to address perinatal mood disorders? Corinna, any thoughts?
Yes, one thing I've discussed this with many people lately is don't try to take it all on yourself, because you're not going to be able to provide what the person needs if you try to take it on yourself. You really need to build a team, and we've talked about this, building this workforce where you can rely on other people, but again, people who are culturally congruent, and they know how to be, not empathy where you're feeling sorry for people in that way, but just where you can listen and understand. So having connections with lactation people, nursing aides, doulas, because you can't do it all yourself. And if you have a network of people that you trust and that you've learned to work within your system, within your clinic or whatever it is that you're doing in this work, you can assign or delegate where that even if you can't see this person 5 times postpartum, and they may need to be checked in many times if the issue is addressed, especially, but even when it's unknown and you don't know, you still need to have a team of people that are checking in. So just delegating those people, it could be a postpartum doula, it could be a lactation person, someone that can just even report back to you if you're not the person directly who can, see that there's something wrong. And that's one thing that I think needs to be implemented more. We've tried to, unfortunately, do a lot of it ourselves in the past, and it's and we have failed at it, and we do get to check in with people we have seen before, people who we've never seen before through our program, but it's still not the same as having a network and support, because that's more people that you can rely on to be checking in with people who really need it without missing anything really important or anything that could be the cause of morbidity or mortality, missing those important things that are red flags, and
Yes.
often miss those red flags because we are not putting in a system in place that works ourselves. We know we
That's
need
right.
it, but we're not taking the action to
Yes.
make it happen.
Very important, and it is part of what we've definitely found as we've gone on our work, on our way through this work, that we've got to consider that part of it is supporting ourselves, supporting each other, sharing the burden. You can't do it alone. It has to be a collective. So if you feel very lonely inside of your environment where you're working because you're the only one working this way, reach out to others, even if they're not in your same institution or your same clinic, and have that support, because we, all of us at the end of the day, are dealing with, I say, the trauma of a system that is so set up so backwards, and many times ends up being lethal. So we cannot take on the harm. We don't want to live vicariously through the suffering that we see some of our patients dealing with, and we don't want to join in and add layers to their trauma or re-traumatize them or re-traumatize ourselves. So that's another important component, and I thank you for bringing it up, Corinna, because it does speak to the fact that as clinicians, we often don't recognize the need to take care of ourselves in the same way.
Yes.
So I appreciate your thoughts. I think that it's important for new clinicians in the work, new people coming on board, to make sure to incorporate in your skill building and in your new transition that you take care of yourself while you're doing it. You go easy on yourself, you're gentle with yourself, and pace yourself. You may not get to full-on practice this way within 6 months. It might take a couple years. It's okay. Just be intentional, keep going. Okay, so I appreciate you coming on to talk with me today. I think that really helps, and I hope that those of you that are listening in gain something from what we've talked about today, and know that this is part of the process, and this is how we do JJ Way. So thank you, Corinna. I
Thank
appreciate
you.
it. Okay.